Great. The next speaker is Dr. Incus Golden. He's a radiation oncologist, medical director of clinical research at Weill Cornell Medicine Department of Radiation Oncology, and associate medical director of clinical trials in the Cancer Center. He will be talking to us about short versus long course. We heard already some, and let's see the point of view of the radiation oncologist.
Okay, can you guys see my screen?
Yes.
Okay, so these are my disclosures. Just, some background. So we have approximately 34,000 rectal cancer cases. There's sort of a bimodal distribution now with the rising incidence of patients that are less than 50 years of age. And this plays a role in our decision-making process in terms of whether or not to do a short course versus long course, and I'll get into that. In terms of the historical classification of rectal cancers and the utility of using radiation, it's primarily based on the fact that the tumors that penetrate through the muscularis have a risk of there being seeding within the lymph nodes. And even with the T2 lesions, there's still like a 15% risk of there being microscopic lymph node spread. So the role of the radiation originally was to try to eliminate the risk for recurrence, possibly even survival advantage. But in the TME era, now it's mostly trying to reduce the risk of recurrence. So there's prognostic features based on the Duke stage once you have either penetration through the muscularis or within the lymph nodes. Radiation, surgery, these are paradigms that were initiated to try to improve outcomes. And this is, just a sort of indicator as to the conversion to the TNM staging after the original Duke staging, but the outcomes are still similar. So one of the major factors in terms of the decision-making process for utilizing radiation treatment is based on the staging. We previously used transrectal ultrasound with good T-stage accuracy. MRI has now supplanted that. However, when we look at the mesorectal lymph node staging accuracy, it's still within the 60 to 70% range. So our therapeutic paradigm has evolved in terms of trying to improve surgery over the past decades, as well as adjunctive therapies, either in the pre-op or post-operative setting. And this is sort of the timeline in terms of trials that have occurred over the decades to try to improve outcomes. We originally started off as like a cancer disease focus, and now patient-centered care is what we're initiating in this day and age, particularly as it pertains to the watch and wait approach. So where long course versus short course comes in, I'll describe briefly. So again, it was shown that negative margins have better outcomes versus positive margins at the time of surgery. And radiation has been introduced to try to improve that. So surgery includes now TME, which is an en-bloc removal of the rectal mesentery, but you're also removing lymph nodes adjacent to the tumor and within the pelvis. And this has been demonstrated to improve outcomes. There's also the transanal excision approach for earlier stage lesions. For patients that have T2 lesions, as Dr. Josh Smith alluded to, with the ACOSOG protocol of doing neoadjuvant chemoradiation, you can allow for those patients to be downstage and undergo local excision. So these are the historic TME results, but there are some indications for adjuvant chemoradiation, particularly for patients with poor risk features or those that have a T2 after a local excision. These patients have a risk of there being micrometastatic spread. So in this setting, we use chemoradiation long course and not necessarily short course. So the postoperative versus preoperative approach has been entertained. We now lean more towards a preoperative approach based on the German rectal cancer trial being a pivotal study. But historically, patients were treated with both postoperative and preoperative. And within the postoperative setting, all of the clinical trials have been done with long course chemoradiation, whereas the preoperative approach has been done with either long course chemoradiation or short course radiation. So this is, sort of the older studies, again, looking at the use of chemoradiation versus radiation versus chemo or observation. And again, these are long course chemoradiation, given that these patients underwent surgery. And so lower doses per day was deemed safer. And then with the addition of chemotherapy as a radiosensitizer, outcomes were demonstrated to be improved. This is a pooled analysis, just comparing various therapeutic paradigms in the postoperative approach. And in summary, so postoperative radiation, particularly for patients with T3, T4 and positive disease. So those are the Dukes B or C or stage 2 or 3. These patients have better local control. And the issue is that in the TME setting, it hasn't really demonstrated improved overall survival. Chemotherapy added to the radiation does show improved overall survival. But the important factors are the number of nodes, the type of surgery, and the margin status. So advantages of preoperative treatment. Now converting patients to preoperative treatment, the tumor is better defined. There's less normal tissue that's irradiated, particularly for patients that are going to go for surgery. Now we're doing a watch and wait approach. So we're still looking at some of the long-term outcomes in terms of toxicity. There's a downstaging potential, again, that helps to reduce the circumferential margin being positive. There's also increased resectability, enhanced sphincter preservation. And then now we're looking at novel radiation chemotherapy combinations and the timing of which. Disadvantages are that because we don't have 100% accurate nodal and tumor staging, we tend to overtreat patients that may actually be earlier staged. And then also we may be overtreating patients with undetected metastatic disease. And this is where ctDNA is helping to define. There's loss of prognostic information in regards to the lymph nodes, particularly for patients with preoperative treatment. And again, the staging is dependent on imaging. So common preoperative strategies, as I mentioned before, is short course radiation, which is 25 gray in 5 fractions that's delivered over 1 week. The paradigm has generally been that surgery is done about a week after radiation, and then patients could get pathology-informed chemotherapy based on nodal status. Also, long course chemoradiation based on The previous paradigm of postoperative radiation, giving a little bit of radiation per day, 1.8 gray per fraction, on order of 45 to 50.4 gray. This can be given with chemotherapy as a radiosensitizer. Patients thereafter go for surgery, and then they can be considered for tumor-informed chemotherapy. And much of this landscape has evolved, whereby we're now doing TNT, and I'll get into that as well. But one of the earlier short course radiation studies in the pre-TME era, 25 gray and 5 fractions versus surgery alone, did demonstrate improved overall survival. However, it was criticized for high recurrence rates within the surgery arm. And these are the survival curves, again, based on stage. So higher stage, stage 2 or 3, demonstrate improved survival as well as local recurrence rates. In the TME era, so now that we're removing adjacent lymph nodes and lymph nodes within the pelvis, the short course radiation on this post-TME era rectal cancer trial did not demonstrate improved overall survival, and the radiation arm did show that there was improved local recurrence rates. As you can see on the right, figure 2, local recurrence rates were better in the radiation and TME arm. In conclusion, so the local control was excellent with TME. RT doesn't impact survival, and this study does not address the impact of modern chemotherapy. This is a trial of, so the MRC trial, looking at sort of an adaptive approach in doing treatment. So short course radiation in the neoadjuvant setting versus selective post-op chemoradiation. In this trial, this compared the short course versus the long course, and given the short course up front in the neoadjuvant setting, there's better local recurrence rates, but no difference in overall survival. So pre-op radiation reduces local recurrences within this setting, but the pre-op versus post-op selective management was compared, but it's not something that we typically do in the modern era. This is looking at pre-op chemoradiation, particularly for T3 disease and multiple clinical trial settings. And so basically, the upfront chemoradiation allows for more downstaging, improves sphincter preserving operations. And then now we're getting complete pathologic responses in 10 to 20% of patients. This is the pivotal German rectal cancer trial that, again, affirmed that preoperative chemoradiation improved local recurrence rates. There's complete response rates in this trial, although it wasn't a primary endpoint, but it was around 8%. And then also there's a better sphincter preserving rates for these patients with tolerable toxicities, and then the recurrence rates are better with the preoperative chemoradiation. So this sort of pivotal study made it a standard of care treatment for doing pre-op chemoradiation. We adopted this for the United States, and that had been standard of care for for a pretty long time. So this is the R03 confirming that pre-op chemoradiation improves outcomes. There was also a trend towards improved overall survival. Capecitabine is an effective alternative, and what we see is that when we're given in retrospect, a continuous infusion Similarly, with the blood levels of the capecitabine, you get better pathologic complete responses versus doing the 96-hour infusions at week 1 and week 5. So chemotherapy in the modern era, particularly on the MOSAIC trial, demonstrated improved probability of survival, particularly for patients with node-positive disease. And so now this had been incorporated as a paradigm as a TNT approach. Oxaliplatin was also visited in terms of neoadjuvant pre-op treatment. We do see some improved responses. However, the toxicities are higher as well. This was introduced in our ACOSOG trial of low-lying rectal tumors T2 that go for neoadjuvant chemoradiation. So they get 5-FU-based chemo and oxali, and then if they have the ability to be resected, then they undergo resection and you're able to do organ preservation. That was one of the earlier organ preservation trials. The importance of a complete pathologic response, as was mentioned by Dr. Smith, is that there's improved disease-free survival. So now in this TNT era, the paradigm includes looking at trying to give chemotherapy and chemoradiation to improve outcomes. And so the sequencing of which has been tested, particularly in the OPERA trial, whereby given consolidative chemotherapy after chemoradiation improves the ability to achieve a clinical complete response in the watch and wait approach. Before the OPERA trial, this study by Dr. Aguilar looked at the combining of chemoradiation followed by increasing cycles of chemotherapy. And what they were able to show is that group 4 had improved pathologic complete responses. And that was the 6 cycles of FOLFOX chemotherapy versus group 1 and the others with a less pathologic complete response. So this allowed for the OPERA trial, which was to test to see if we can achieve a watch and wait approach for patients that achieve clinical complete response. And so this is the non-operative approach by Dr. Garcia Aguilar that was published. It's the OPERA trial. And patients were randomized to either receive induction chemotherapy followed by chemoradiation or consolidative chemotherapy after chemoradiation. And then they get restaged with DRE, endoscopy, and MRI. If they have a clinical complete response, they go watch and wait. If anything less, near complete response, then they undergo a TME. And so Dr. Smith, demonstrated or showed within his presentation that there were high TME survival rates for patients that underwent this TNT approach, better numerically with the consolidative chemotherapy after chemoradiation. However, there are patients that do have regrowth after they undergo neoadjuvant treatment in a watch and wait approach. So there are some direct comparisons of long course versus short course. And the Polish study tried to interrogate on a randomized phase 2 trial. Unfortunately, it was a superiority study. They believed, based on their evidence, that preoperative short course radiation was superior to long course chemoradiation. And so the design was to look at superiority and not a non-inferiority study. And they didn't show superiority, but numerically, the outcomes were similar. So This was probably the closest head-to-head comparison, just directly looking at short course versus long course. There's the TROG study. This was also looking at short course versus long course, particularly in patients with T3 rectal cancer, and they didn't see any difference, again, with the 3-year local recurrence rates numerically. However, when they looked at patients with distal tumors, they found that there was a reduction in local recurrence rates with the long course. So we tend to err on leaning more towards doing long course chemoradiation for patients with distal tumors, so within the 5 centimeter of the anal verge. So the Rapido trial, again, this is a comparison of looking at TNT, but they did compare short course radiation followed by chemotherapy and surgery versus long course chemoradiation. This is, a caveat here, so it's not a complete direct comparison. However, they did show that they met the 3-year disease free survival primary endpoint of improved outcomes in the experimental arm, which was the short course. But the patients did receive preoperative chemotherapy, and it was better tolerated. So the Rapido was powered to look at the primary endpoint of disease-related treatment failure. But when we look at the 5-year results, even though it wasn't powered to look at local regional failure or local regional recurrences after R0, R1 resection, they did demonstrate that there were some late recurrences, more with local recurrences within the short course arm. However, on multivariate analysis, there were also within the experimental group, the short course radiation arm, the enlarged lateral lymph nodes were also associated with local recurrence. And then they did a deeper dive looking at the treatment modality, 3D versus IMRT, and patients that received the short course radiation were more often given 3D. When you controlled for that factor, the local recurrence rates were comparable between the experimental and the standard arm. So the question is, whether or not 3D conformal radiation underdoes some of the pelvic lymph nodes, contributing to higher local recurrence rates. That's a question for debate. The Stellar trial also tried to look at this TNT approach, also with the short course radiation. And they were also able to show that there was improved 3-year disease-free survival with short course radiation TNT versus the long course chemoradiation. And they also demonstrated improved 3-year overall survival. Again, this is not a direct comparison, but it just lets you know that short course radiation is a viable therapeutic treatment. This is a Stockholm trial that compared, it was initiated in the late 90s, early 2000s. In terms of enrollment, they compared short course radiation followed by surgery after 1 week versus short course radiation followed by delayed surgery, so at the 6 to 8 week time point, versus long course radiation followed by delay. And what they were able to show is that there were no difference in terms of the local recurrences between either arm, and the complication rates when you look at short course radiation and immediate surgery versus delay surgery, complication rates were better with the delay, particularly as it relates to any surgical complication. So some of the decision-making strategies for rectal cancer management in terms of radiation delivery for elderly or comorbid patients, These could be patients, that can't travel for these long periods of time. So 5.5 weeks of treatment, may not be able to tolerate chemotherapy. So for these patients that are, uh, intermediate, being, they have a dependence on greater than one ADL, or comorbidities, but not life-threatening, or memory disorders or depression or some geriatric syndrome. These patients can be considered for short course radiation alone. Um, and then for those that are really frail, again, short course radiation should be a consideration for those patients. Um, we have the fortunate uh, collaborative group that we've put together. This is a radiation oncology biology integrative network, or ROBIN, NIH sponsored study. We're looking at what are the molecular features of short course radiation. And so we're collecting specimens before and after short course radiation, and then we're trying to get a better understanding as to what radiation does. We also look at the radiation effects of on the tumor, as well as the tumor microenvironment, and then the radiation effects on the immune cells and the microbiome. So we're collecting tissues. We're doing spatial transcriptomics, as well as the RNA-seq within the blood samples, and then integrating all of this information to be uploaded into a database to be shared with the public. We've demonstrated some preliminary findings looking at sequential specimens as compared to baseline versus post-radiation treatment. We see a marked reduction in tumor burden across the specimen, and this is just radiation alone. There's a decrease in tumor cell proliferative activity, reduction in the M2 immunosuppressive macrophage activity. However, once we get to the time of surgery versus immediately after radiation, the tumor burden rebounds towards baseline. There's increased proliferative activity within the tumor cells, and it actually is restored beyond baseline. And there's expansion of M2 macrophages that corresponds to a wound healing sort of process. We're also looking at how can we subvert this immunosuppressive paradigm. And adenosine signaling has been demonstrated within colorectal cancer alone, looking at there's a TCGA database where it was interrogated, and the reads that came out were patients that have rectal adenocarcinoma and colorectal adenocarcinoma at the highest in terms of this adenosine signaling. And this is part of this wound healing process that is exacerbated even more by radiation. And we're looking at blocking this pathway to see if we can improve immunologic outcomes. So we have an inhibitor that's a adenosine receptor antagonist of the A and B receptors, and we're testing this within patients that are receiving total neoadjuvant treatment. And so this is the protocol that we're treating. So patients are getting short course radiation. We believe that short course radiation, even though there's increased M2 macrophage immunosuppressive activity, we do believe that this treatment paradigm is less immunosuppressive, meaning that given long course chemoradiation, you can get lymphopenia, where you're giving a little bit of radiation. There's immune cells that traverse through the radiation field, and you have increased immunosuppressive activity just on the radiation on the immune cells alone. whereas short course radiation, the impact is not as great. So we've selected short course radiation as part of the paradigm to see if we can improve outcomes by modulating the immune system with this adenosine receptor antagonist. Patients also receive a PD-1 checkpoint inhibitor at the time of which they receive their standard of care FOLFOX chemotherapy. There's also a clinical response assessment, and then patients go for surgery. Just preliminarily on the patients that we've treated on the phase 2 portion of the study, we have a composite complete response, meaning a clinical as well as pathologic complete response on the order of 70%. And when you look at other trials, including those of which that are receiving immunotherapies, and then also when we're comparing the OPERA trial, this approach does show some promise, whereas the other trials are demonstrating a composite complete response in order of 40 to 50% range. So the takeaway is that short course versus long course radiation should be situational and patient dependent. And all of our cases we review at our tumor boards, and I think that's a good approach. But also patients' wishes should be taken into account. Patients travel that, in some cases long distances. Elderly patients may be seeking convenience. So patients may not be able to tolerate chemotherapy. Maybe they have a second malignancy. They may already be immune suppressed. And then we do believe that short course radiation may have less of an immunosuppressive treatment. So on an immunotherapy protocol, there may be better outcomes. And then patients with metastatic disease, where you're palliating the primary tumor, short course radiation could be a consideration. Long course chemoradiation. So in today's era of the watch and wait approach, which Dr. Smith, elaborately presented on, long course chemoradiation has been the treatment of choice. However, as we're looking at immunotherapy approaches, short course radiation may also have some ability to get patients in the watch and wait approach. Patients with distal tumors, so within 5 centimeters of the anal verge, should be considered for the long course chemoradiation, just given that we have more data of the watch and wait approach for long course chemoradiation. And then thinking about the Rapido trial, patients with T4 and 2 disease, the long course chemoradiation should be a consideration, and then in the post-op setting as well. So thank you.
Thank you, Dr. Golden. This was very comprehensive. I really like the history, which is something I'm passionate about. And the last slide, I think, summarizes what we discuss every Thursday at the tumor board, in a very organized and simple way. There was a question in the QA that the talks will be recorded, are being recorded, and will be on the website shortly after. A few days after the webinar, so you'll be able to watch whatever talks you're interested in. It's not the whole 5 hours. And in the interest of time, I'm going to move on to the next talk. Again, thank you, Dr. Goldman.